What is an embolus? It is a detached intravascular solid, liquid, or gaseous mass that is carried by the blood to a site distant from its point of origin. So, the impact of an embolus in a vessel whose caliber is too small to allow the embolus to pass, leading to vascular occlusion, is an embolism. So an embolus is a detached intravascular solid, liquid, or gaseous mass that is carried by the blood to a site distant from its point of origin. And an embolism is the impact of an embolus in a vessel whose caliber is too small to allow the embolus to pass, leading to vascular occlusion. Almost all emboli are thromboemboli, embolus derived from part of a dislodged thrombus. But there are other, much less common types. So these could be things such as vegetations, infected heart valves, mycotic aneurysms, or fragmentation as tumours penetrate vessels, or chest wall injury, iatrogenic ones, pressured air leading to rapid decompression, leading to nitrogen release, or AF into uterine veins during childbirth, that's got an 80% mortality, or trauma leading to breaking of long bones, burns, soft tissue injury, and CPR. So emboli can also be classified by their location. So you've got venous emboli, so the venous system, commonly the legs, and pulmonary, leading to pulmonary embolism. Arterial or systemic emboli, so the arterial system would go to the brain, the limbs, or organs. And paradoxical embolisms. So I'm just going to Google paradoxical embolism quickly. A paradoxical embolism is a kind of stroke or other form of arterial thrombosis caused by embolism of a thrombus, blood clot of venous origin, through a lateral opening in the heart, such as a patent forum ovale. So the opening is typically an atrial septal defect, but can also be a ventricular septal defect. So paradoxical embolisms represent 2% of arterial emboli. So it's things like where you get a stroke, which normally be as a result of an arterial emboli, but instead you get it as a result of a venous emboli, which has then gone through into the different system via a thing such as a patent foramen ovale in the heart. So, pulmonary embolisms, a very important clinical entity, up to 60,000 deaths per year in the UK. If untreated, the risk of death from a pulmonary embolism is 87%, 95% from venous thrombosis in deep vein legs or the pelvis. So 95% of pulmonary embolisms are deep vein thrombosis. Fragmentation of the deep vein thrombus, and then you get an embolus which enters the inferior vena cava, which then passes through the right heart. Then there's impaction and occlusion in pulmonary circulation. So blood clots that occlude the large pulmonary arteries are virtually always thromboembolic, DVT in origin. In situ pulmonary artery thrombosis is rare. The risk factors of pulmonary embolism are the same as thrombosis, so Virchow's triad. So, blood clots that occlude the large pulmonary arteries are virtually always thromboembolic. In situ pulmonary artery thrombosis is very rare, like really rare. And risk factors for PE are the same as thrombosis. So we're looking at Virchow's triad. So they'd be the same because obviously thrombosis is what is required to get a pulmonary embolism pretty much. So we're looking at atherosclerosis and hypertension, which would be examples of endothelial injury, and also hypercoagulability. So things like malignancy, surgery, oral contraceptives, pregnancy, antithrombin 3 deficiency, protein C or S deficiency, factor 5 mutations, which is Leiden syndrome, and they're all things which lead to hypercoagulability. And then also the third bit of the triangle is abnormal blood flow. So these would be things such as immobility, so things like hip fracture, long flights, surgery, those sort of things. So there are, whilst endothelial injury, hypercoagulability, and abnormal blood flow are the three peaks of the triangle, and they all lead to the central thrombosis, the abnormal blood flow has an arrow going to endothelial injury, because abnormal blood flow can lead to endothelial injury, and likewise the arrow goes back because endothelial injury can lead to abnormal blood flow. And also an arrow going from endothelial injury to hypercoagulability, because endothelial injury from atherosclerosis, hypertension, smoking, etc. can lead to hypercoagulability. And hypercoagulability, abnormal blood flow also leads to hypercoagulability. So there are no arrows going from hypercoagulability, just arrows going from both of the other two. So, like a classical history of pulmonary embolism would be 5D post-hip replacement, sudden onset, dyspnea, hypoxia, and tachycardia. And dyspnea is shortness of breath. So dyspnea is shortness of breath. So classical history of someone with a pulmonary embolism: 5D post-hip replacement, sudden onset, dyspnea or shortness of breath, hypoxia, and tachycardia. Effects are dependent upon the size of the vessel blocked. So large pulmonary vessels, the main pulmonary artery. So if the main pulmonary artery is where the embolism occurs, you can get a straddle bifurcation or a saddle embolus, and that would lead to death because it's blocking all the blood flow. So pulmonary emboli beyond bifurcation but proximal can also be fatal. But obstruction of 60% of pulmonary blood flow is what would definitely cause a death. And the only thing you can actually use is CPR, leading to pulseless. Okay, so they're saying that CPR would cause pulseless electrical activity because you're pumping the heart, and the heart can be pumping still, but you're not going to be getting a pulse because obviously the blood flow isn't actually going anywhere. So this would be a cause of instantaneous death. So if you think about it, the blood just can't flow around anymore. So medium-sized pulmonary arteries, occlusion can lead to vascular rupture, so you can get a pulmonary hemorrhage. Pulmonary infarction you wouldn't usually get, so in 90% of cases you don't get pulmonary infarction. And the symptoms of a medium-sized pulmonary artery occlusion and pulmonary hemorrhage would be chest pain, pleuritic pain, and dyspnea, so shortness of breath. So now moving on to small end arteriolar pulmonary branches. So you get no hemorrhage on infarction. Small end arteriolar pulmonary branches, you get no hemorrhage or infarction. But multiple emboli over time may cause progressive obstruction to vascular flow. So you can get pulmonary hypertension and right ventricular failure. So most pulmonary embolisms, 60 to 80%, are clinically silent. For predisposing conditions, 30% chance of repeat of pulmonary embolism. So if you've had one pulmonary embolism, there's a 30% chance of a repeated pulmonary embolism. So now looking at behavioural causes, e.g. on flights. So TED stockings are thromboembolic device or thromboembolic deterrent stockings. They're graduated compression stockings. So thromboembolic device or thromboembolic deterrent, and they're graduated compression stockings. So they can be and you can also have anticoagulation, for example heparin, and IVC filter, Greenfield filter. Okay, so systemic thromboembolism, these occur within the arterial circulation. So 80% are from intracardiac mural thrombi. So myocardial infarction, atrial fibrillation, etc. So they occur within the arterial circulation. 80% are from intracardiac mural thrombi. So myocardial infarction leads systemic thromboembolisms occur within the arterial circulation. 80% of systemic thromboembolisms occur from intracardiac mural thrombi. So these would be things such as myocardial infarction, atrial fibrillation, etc. But they can come from other sources, so you can get an aortic aneurysm thrombus, or atherosclerotic thrombus, or paradoxical embolism. Now, with ischemic injury, limbs 75% of the time, the brain 10% of the time, and other viscera would be the other 15%. So, ischemia and hypoxic injury. So, hypoxia is any state of reduced tissue oxygen availability. So, generalized whole body, e.g. altitude and anemia. Regional would be where specific tissues are affected, and hypoxemia is a clinical measure of low PaO2. So, ischemia is a disease characterized by reduced blood supply. So, ischemia is a restriction of blood supply to tissues causing a shortage of oxygen and glucose needed for cellular metabolism. So, ischemia is a shortage of blood supply. So, restriction to blood supply is ischemia, which is different from hypoxia, because hypoxia is just simply a lack of oxygen. So, generalized hypoxia is likely to be just hypoxia. Regional hypoxia, where specific tissues are affected, is quite likely to be ischemia. So, non-ischemic hypoxia, e.g. with altitude, impaired oxygen supply only, so other metabolites are still supplied, for example, glucose. And with ischemia, there's a decreased supply of metabolites, including glucose, and then you get glycolytic anaerobic respiration, and then a decrease due to a lack of glucose, and a buildup of metabolites, which impairs anaerobic respiration further. So ischemia injures tissues faster and more severely than hypoxia. So looking at ischemic injury, if there's a limited or a short duration, then cell injury is reversible. So rapid restoration of blood flow can be therapeutic. And then if we're looking at prolonged or sustained, then irreversible cell damage occurs and we get cell death. So the type of cell death in ischemic injury would be necrosis. And what is tissue called when caused by ischemia? Necrotic, perhaps? Not sure about that one. Okay, so tissue reperfusion is generally good, but only if is ischemia reversible. So, for example, with rapid PCI for MI and thrombolysis for stroke, if not reversible, it's sustained, then damage can be permanent, so reperfusion of infarcted tissue will have no effect. And if reperfusion of non-infarcted but ischemic is reperfusion of non-infarcted but ischemic tissue always good? No, because you can get ischemic reperfusion injury. So what is infarction? So an infarct is the just going to Google it. Infarct is an area of tissue that undergoes necrosis as a result of obstruction of local blood supply, as by a thrombus or an embolism. An infarct is an area of tissue that undergoes necrosis as a result of obstruction of local blood supply, as by a thrombus or embolism. So what causes the majority of infarctions? Most cases of myocardial infarction no, this is myocardial infarction. Just infarction in general. Well, the most common cause of myocardial infarction is due to occlusion of a coronary artery following the rupture of a vulnerable atherosclerotic plaque, which is an unstable collection of lipids and white blood cells in the wall of an artery. A cerebral infarction can be atherothrombotic or embolic. So stroke can be caused by cerebral infarction, which okay. Now looking at venous occlusion. So this also causes infarction but is uncommon. So common clinical outcome, venous obstruction and congestion, but no infarction, and smaller branches or collaterals open up and allow blood to bypass the obstruction. So with a venous occlusion, a common clinical outcome is venous obstruction and congestion, but no infarction. So the smaller branches or collaterals open up and allow blood to bypass the obstruction. So with organs with a single venous outflow, for example the testes or the ovary, they're vulnerable to venous infarction because they've got no sort of collateral escape route. So infarction can be classified. So the two types of infarction are hemorrhagic infarction and anemic infarction. And so with hemorrhagic infarction, there's dual blood supply, so these would be venous infarction, and with anemic infarction, there's a single blood supply, hence totally cut off. So with anemic infarction, there's a single blood supply, so it's totally cut off. Most infarcts are wedge-shaped, and that would be because of the different branches. So you've got a branching artery, so it's giving off lots of different threads. So all the arteries that are given off from the main infarction, that area of tissue which is perfused is going to be ischemic because it's going to get a lack of oxygen. So if a person dies suddenly, so like with a massive heart attack, what do you see in the tissues? I would say you don't see anything, particularly because the body won't have had the sort of immune response, the blood response, etc. So the histological characteristics of infarction would be different in the brain, I reckon, because So, morphology of coagulative infarction. Coagulative necrosis with neutrophil infiltration. We're looking at the gross features and the microscopic features after a set period of time. So, within 24 hours, the gross features of a coagulative infarction be normal, and the microscopic features also normal. But within 1 to 2 days, the gross features would be pale yellow and edematous, and the microscopic features would be coagulative necrosis with neutrophil infiltration. So first, we get the neutrophils, and it's pale yellow and edematous. Within 3 to 4 days, it's yellow with a hemorrhagic edge. So coagulative necrosis with macrophage infiltration. So first we get the neutrophils, then we get the macrophages, and we're having coagulative necrosis. And first it's pale and yellow, and then it becomes darker yellow, a stronger yellow, with a sort of hemorrhagic edge. Within 1 to 3 weeks, the gross feature shown would be pale and thin, and the microscopic feature, granulation tissue, is now being formed. And then by 3 to 6 weeks, you get a dense fibrous scar being shown, and also microscopically, there is dense fibrous scar. So you've got neutrophil infiltration followed by macrophage infiltration within the first few days. Then within the first few weeks, you get granulation tissue formation and then a dense fibrous scar. And so it goes from pale yellow to pale to a dense fibrous scar being present. So effects of vascular occlusion is variable and depends on 4 factors. So effects of vascular occlusion is variable and depends on 4 factors. So it depends on the nature of the blood supply. So an alternative blood supply will mean less damage, hence severe ischemia required for infarction. So an alternative blood supply is the most important factor in determining if vascular occlusion will cause damage. So in the lungs, you've got the pulmonary and bronchial arteries. In the liver, you've got the hepatic artery and the portal vein. In the hand, you have the radial and the ulnar artery. So tissues with a dual vascular supply are generally resistant to infarction of a single vessel. So with the kidneys, the spleen, the testes, etc., they have an end arterial circulation. So there's an artery-only blood supply. Hence, they are vulnerable to infarction. So this is the kidneys, the spleen, and the testes, as an example. So another variance of the effect of ischemia is a result of the rate of occlusion. So with slow developing occlusions, there's less likely to be infarct tissue, because this allows for time for development of an alternative perfusion pathway, so a collateral supply. So in the heart, small anastomoses normally connect the major branches of the coronary artery system and have minimal flow. If a coronary arterial branch is slowly occluded, flow can be directed through these channels. Infarction can be avoided even if the main arterial branch is totally occluded. Another thing that can vary the effect of ischemia is the tissue vulnerability to hypoxia. So in the brain, if a neuron is deprived of oxygen, how long does it take to undergo irreversible damage? Not very long, whereas in the heart, it's slightly more resistant. So this, I believe, would be because in the heart, it's not as metabolically active as fibroblast death takes longer than myocyte death because it's not as metabolically active as heart muscle cells. But the heart is slightly more resistant to ischemia than the brain. So effects of ischemia. Finally, we've got to look at the blood oxygen content. So reduced oxygen in the blood, anemia, etc., you're going to be more vulnerable to infarction. So with congestive heart failure, you've got poor cardiac output and impaired pulmonary ventilation. So the infarct in a normally inconsequential narrowing of vessels would be able to occur due to the impaired oxygenation of the tissues. So looking at now low flow infarction, infarctional areas of diminished blood flow in vulnerable anatomical regions. So this is called a watershed region, which is a point of anastomosis between two vascular supplies. So the splenic flexure colon, SMA, IMA, myocardium, ventricles and coronary arteries. So places where you can get infarction where there's low flow, you get them in the watershed regions, such as the splenic flexure of the colon and the myocardium. The point, because these are a watershed region is a point of anastomosis between two vascular supplies. So the portal vasculature is where blood is supplied via other parenchymal capillary beds. So anterior pituitary via the hypothalamus and renal tubules via the glomeruli. So clinically relevant manifestations of ischemia or infarction. In the heart, ischemic heart disease, angina or MI. In the brain, stroke or cerebrovascular accident. In the intestines, bowel infarction. In the extremities, gangrene. Ischemic heart disease is clinically very important. It's the leading cause of death in men or women in the West. So ischemic heart disease causes more deaths than cancer. It's 90% of the cases of cardiac ischemia are due to impaired coronary arterial flow following complications of atherosclerotic disease. Now looking at cerebrovascular disease, it's the third leading cause of death in the West. It refers to any abnormality of the brain caused by pathological process involving blood vessels. So the three broad categories of cerebrovascular disease are thrombosis, embolism, and hemorrhage. Now looking at a stroke, the clinical manifestation of the effects of embolism, thrombosis, or hemorrhage in the brain that result in focal or general cerebral ischemia. What does CVA stand for? The most common causes of strokes are thrombosis secondary to atherosclerosis, embolism, hypertensive intraparenchymal hemorrhage, and ruptured aneurysm. So now looking at cerebrovascular disease, remember that the endpoint of the above processes is impaired supply of oxygenated blood to the brain, i.e. ischemia. Although the brain is 1 to 2% of total body weight, the brain requires 15% of cardiac output. The brain is very vulnerable to oxygen deprivation. Looking at blood supply to the brain, it's just showing how complicated it is. Cerebral arterial occlusion leads to focal ischemia and infarction of a specific region of the brain supplied by a specific vessel. Cerebral arterial occlusion leads to focal ischemia and infarction of a specific region of the brain supplied by a specific vessel. Regions that don't have collateral flow are vulnerable to infarction. So this is the thalamus, the basal ganglia, and deep white matter. The majority of thrombotic vascular occlusions are caused by atherosclerosis, carotid bifurcation, the origin of the middle cerebral, and the basilar artery. Embolism can cause cerebral infarction, and vascular territory commonly affected by embolism would be the middle cerebral artery. Emboli pass from the internal carotid directly to the middle cerebral. Clinical features of cerebral infarction. This would depend on the affected vessel. It may be asymptomatic. You can get hemiplegia, sensory abnormality, blindness, and aphasia. So, watershed, again, would be infarction at site of anastomosis or between two arterial territories. So, looking at the watershed infarcts that can occur, there's the cortical border zone, which is between. There's the cortical border zone, the internal border zone, and the cortical border zone at the other side of the brain. So looking at the brain, going from anterior to posterior. It's just going straight through the middle. So ischemic bowel disease is where is as a result of thrombosis or embolism. It can happen in the superior or inferior mesenteric arteries, and abdominal pain is a clinical sign of that. Looking at limb ischemia or infarction, you can have gangrene. So this would be infarction of, for example, an entire portion of a limb or an entire portion of an organ. You can also get you can get different types of gangrene, so like dry gangrene, wet gangrene, gaseous gangrene.